Welcome, everyone.
Yeah, good evening, everybody. So nice to have you join us. Happy August.
Yeah. Oh, happy August. Hope
Hmm.
you're all enjoying the summer. It's flying by.
Yeah, yeah. And enjoying it as well.
Yes, yes, yes.
Mhm.
We've got a new topic tonight, so this is great. We're so happy to have one of our advisors with us, really honing in on HER2 and hopefully providing some insight and some clarification to those of us that are joining and those that will be watching in the future. So we're excited to have this segment and to hear what's coming up.
I know, I agree. There's so many breakthroughs. We were just talking about that with Dr. Lustberg and just saying
Yeah.
how it's so important that we keep up and we have advisors like Dr. Lustberg to keep us ahead, understanding the new breakthrough, the newest technology and the newest breakthroughs in this type of personalizing, therapies for treatments. So really, really glad that she's able to join us tonight.
Absolutely. So if you have not seen the title, I'm sure you have, and it's been all over social media because we're so excited to be featuring this topic. Tonight we're looking at HER2 as a target in breast cancer. How do we measure and act on personalizing therapy? So Dr. Lustberg will be going through the varying levels of HER2, and of course we'll have some time for questions, Q&A at the end. And of course, our recording tonight will be in our video library as early as tomorrow. So before I think we get into anything, we should probably introduce ourselves for those that are new to our UFH
Um,
Connect video library. My name is Erin Pellegrin. I'm our Senior Director of Culinary Nutrition and Education. I am often hosting these education events with my sidekick here.
It's me. I'm Sue Weldon. I'm the CEO and founder of Unite for Her, and we are honored to be in this space. If you have not gotten a chance to get on our UFH Connect library, please get in there. It is so robust, and we have been doing this now together, Erin and I, for 5 years. And the content, we do an inventory of the content, making sure that everything is up to date. And boy, any topic that you can think of, it is probably there. And if it's not, please tell us. Send us an email because we're always looking for new ways that we can bring information that our community is really looking for. So I love looking at that library, Erin, and all the
It's got
years,
a lot.
all the incredible speakers and experts that we've had
Mhm.
showcased on this channel. It's exciting.
It is very exciting. And Sue's right. If you're looking for something or a topic or discussion in particular, chances are we've covered it. So
Yeah.
we'll be sure to put that link to our video library in the chat. And
Yeah.
with that, I do want to give thanks to our sponsors because they are part of the driving force that allows us to continue to bring important discussions and topics like tonight to our UFH Connect library and to our Unite for Her community. So, of course, our virtual education events tonight are presented by West, Merck, Lilly, Novartis, and Gilead Sciences. We have additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo. And we have additional support from AbbVie and Tercera Therapeutics. So we are so grateful for their ongoing support for all of our segments, all of our discussions, and we will continue to bring you amazing topics and speakers continuing off through August and the rest of the year. And we're planning 2026, and we'll just continue to get better and better.
Yeah, you got it. Thank you, Erin. And then we always like to give you an idea what's coming up too, so you can plan your calendar. And if you watch us on social media, we always put these front and center. Erin's going to pop a little calendar reminder in the chat. But on August the 13th at 5 p.m., we have a virtual hangout. We are coloring in community with Grace Childers. She's a master's of art therapy and counseling. Very excited to have her there. And if you were one of our first 50, I believe, Erin, to sign up, you have your very own coloring book and pencils. So we're excited to do some art therapy together. And then on August the 21st at 6 p.m., her speaker series, we're going to be nutrition focused treatment toolkits. Explore our expert-backed guides for chemo, radiation, surgery, hormotherapy with the nutrition strategies to help you thrive and prepare. So these are guides that we have available right on our nutrition resource page. Talk about a robust part of Unite for Her's therapies that we offer with the passport and in general with our Empowered Living program. but nutrition is front and center. We have a lot of guides that really take the guesswork out of trying to do the research behind a lot of these topics. And please know that we're going to be there to go through all of that with you on the 21st of August, but then also give you a place where you can land and recall them and download them and take photos of these guides so that you have them handy. So we have all of that with you, ready for you on the 21st.
Perfect. All right, wonderful. Well, I think we've covered everything, Sue. Why don't we jump right in, because we've got a lot to cover. So it is my pleasure to introduce our speaker for this evening. So Dr. Maryam Lustberg is the director of the Center for Breast Cancer at the Yale Cancer Hospital and Yale Cancer Center, as well as chief of Breast Medical Oncology at Yale Cancer Center. She's also a professor of medicine in medical oncology and has been widely recognized for her patient-focused care. Dr. Lustberg continues her research efforts at Yale by emphasizing on improving the long-term outcomes for patients with breast cancer who have developed side effects associated with treatment. And tonight, she will be covering all about HER2, varying therapies. So please join me in welcoming our guest tonight, Dr. Maryam Lustberg.
Thank you so much, Erin and Sue. Can you all hear me?
Yes.
Can hear you great. Perfect.
Great. So happy to be here tonight. My disclosures are here, and I will not be doing any off-label discussion during this presentation. So we'll be talking about all approved indications. And so this is a really exciting, important topic. It will be mostly focusing on the HER2 signal in breast cancer. However, it applies to many other cancer types, including ovarian cancer. And so as appropriate, I will highlight how we have really gone beyond breast cancer alone with this HER2 pathway. It's one of our most important pathways in oncology. So I'll first introduce what it is, how we measure it, and then talk about more clearly positive tumors, and then introduce the idea of what we call HER2 low and ultra low tumors, and give you a little bit taste of what is to come in terms of future directions. So this is a movie that some of you may have seen, Harry Connick Jr. This was a Lifetime movie called Living Proof, and it tells depicts the story of Dr. Dennis Slayman, who, along with really a number of important figures, including patients and patient advocates, philanthropists, regulatory agencies, essentially led to the first approval of Herceptin. And we're going to talk about what Herceptin is, but essentially the first HER2 monoclonal antibody for HER2 positive breast cancer. And it completely changed how we think about HER2 positivity. Before the approval of Herceptin and kind of the discoveries that led to this, essentially, for a long time, we weren't even testing for HER2. And even when folks were beginning to test for HER2, because we actually didn't have a drug to target the HER2 protein, what patients would hear, let's say 25, 30 years ago, was, I'm sorry, you have a very aggressive type of cancer. You're going to have terrible outcomes. It was quite devastating. So many of these patients, even when they were diagnosed in the early, potentially curative setting, would have very rapid relapses to the metastatic setting. And the way I describe what HER2 protein is it's a protein. The fancy name for it is an oncogene. A way that I describe it to my patients is like it's extra growth antennas. So if it spans, there is a part that's outside of the tumor cell. And then there's a part that goes inside the tumor cell and basically picks up extra signals and then amplifies them and goes into very intricate signaling pathways that basically, when there is a lot of these HER2 cells on the tumor, they get revved up and they're more likely to grow and divide more rapidly. So obviously that's not a good thing. But then the revolution of HER2 therapies was that we learned very elegantly through basic science, translational research, and clinical trials to essentially outsmart these growth antennas. And so Herceptin is one of them, that normally these antennas come together and couple and uncouple as a way of activation. When they have this bulky antibody called Herceptin attached to them, they're no longer able to activate. So it was a very elegant way of neutralizing this extra growth signal, and really was revolutionary. It's been one of the most important scientific discoveries of our time. And so what used to be kind of, we used to think about breast cancers as essentially breast cancer as one type of disease. Really, with the discovery of this HER2 pathway, we really started to differentiate our breast cancers to those that are primarily hormonally driven, but HER2 negative, HER2 positive, or the ones that we call triple negative, the ones that are negative in all three. And you're going to see this schema change as I present, because it's become a lot more complicated as our understanding of HER2 pathways has evolved and as our drugs have improved. So this figure is an outdated view of viewing breast cancer, but I'm including it here because this is when I started training and when I was an oncologist kind of early in my career. This is exactly how we thought about things. But things rapidly change, and this is one of the ways. I do want to kind of emphasize that HER2 protein is actually normally expressed in all of our normal cells. What makes it pathological, what makes it kind of not a good thing, is when there's a lot of it present. So and it's not unique to breast cancer. It is actually present in a number of different cancer types. It's not been as consistently tested and become part of routine practice in all cancer types. So a lot of our data and a lot of our therapies initially started in breast cancer. But I do want to kind of emphasize that, for example, there's a subset of ovarian cancers that actually about a third of them actually have HER2 positivity. So I think it's important that it's something that we're beginning to think about in a variety of cancers, and some of our drug indications don't care what type of tumor it is. The HER2 positivity itself is gaining access to those therapies, and I will highlight that in a second. So then this slide kind of brings us a little more forward as we started to do more testing and had a better understanding of even different activators of breast tumors, even beyond HER2. The whole field of what we call molecular subtyping. That's just a fancy way of saying that we really started to think about breast cancer as not one disease, but multiple subtypes or multiple types of cancer. And so based on very detailed genomic profiling, so really studying the protein makeup, the RNA makeup, the DNA makeup of these tumors, what was found was that the slowest growing, very endocrine sensitive tumors were known as luminal A. They tend to not respond very well to chemotherapy. And then some of these hormonally driven tumors, which may have extra HER2 signal, are in medical literature known as luminal B tumors. And then we have tumors that are not hormonally driven at all, but have that HER2 signal, and that's called HER2 enriched subtype. And then we have the triple negative, which are known sometimes as the basal subtype. So this may be a lot of information all at once. I promise I will break it down more, but I think the main takeaway from this pie graph is for you to see that more simplified version before, and how, as we did more research, our understanding of the intricacies of breast cancer evolved. And then we began to do additional testing and understanding of, well, how much HER2 do I need in a tumor to gain benefit from drugs like Herceptin or even the next generation drugs. And I'll show you some pictures of kind of when we have a lot of HER2, what does that look like? When it's somewhere in the middle, what does it look like? And then I'll introduce this idea of HER2 low. But to give you kind of a visual representation of how things are breaking into different categories, about 15% of all our breast cancers tend to be very HER2 positive. And then we have a third of our tumors that are not picking up any signal. And then we have over half of our tumors that actually have a little bit of HER2 signal. And this pie graph is going to continue changing. I'll show you another pie graph near the end, showing that as our drugs have improved, the level of HER2 protein that you actually need in the tumor to derive benefit from these drugs actually continues to increase. So this is another schema kind of showing that this is not just in hormone receptor positive disease. Even triple negative tumors could have that little bit of HER2 signal, making them triple negative breast cancer with HER2 low features. So I'm going to spend a little bit of time on this slide because it's super important. So what these boxes show are slices of a tumor, a breast cancer tumor. The brown areas are staining directed at HER2. So this is antibody staining, kind of grabbing those HER2 protein, and you don't have to be a pathologist to see lots of brown spots here. So these are your most classically HER2 positive tumors. When Dennis Slayman was first studying these tumors, these were the tumors that Herceptin was shown to be most effective against. They have a lot of HER2 signal. So when we use these HER2 antibodies, they are very effective. You also don't have to be a pathologist to see that when we go to the HER2 low area, the proportion of tumor cells that are actually picking up that HER2 signal is much lower. So if you squint, you're going to see some brownness here and brownness here, and there are very specific criteria, and I have a slide on that. But I think visually what I want you to see is the profound difference in how much a truly HER2 positive tumor can pick up different levels of that HER2 protein compared to HER2 low. And then you have these completely HER2 negative tumors. But if you even squinted a little bit harder here, you could possibly convince yourself that maybe there's a little bit of brown here. So we'll come back to this idea. So it's really about these different thresholds. And so about 63% or 2/3 of our hormonally driven breast cancers are picking up at least low levels of HER2, and about 1/3 of our triple negative tumors. And this is me asking you to play pathologist again here. So just kind of visualize in your mind, which of these would you pick as the most HER2 positive, and which would you kind of consider in between or HER2 low, and which you would consider completely negative. I'll give you a minute to kind of play pathologist, like someone would do on TV. And so kind of get your thoughts together. And so again, kind of strong staining is HER2 positive. These are kind of falling in this HER2 low category. And these are kind of very negative. So, and one thing that you may have noticed is that somewhere around here, there's actually a little bit of subjectivity. So a pathologist, no matter how much they're trained, they will have no problem with this. That's clearly positive. They will have no problem with this. But somewhere here is where studies have actually shown that depending on who the pathologist is, they may actually choose differently. So some of them may call this HER2 low, and some of them may call it HER2 zero. So there's a little bit of subjectivity and variability that highlights, and there's a lot of studies, and if there are questions on this, I'm happy to talk about it, but we're doing a lot of innovative research to take the guesswork out of the errors that a human eye can make here, because your life depends on us getting this right. But I just wanted you to visually see how it can be confusing. I have so far shown you kind of how to kind of use that antibody test, essentially use something that picks up that protein signal. But there is another way that we determined HER2 positivity, and we call it the HER2 fish, and I call it fishing for HER2. And this is a picture of it. And the idea is that sometimes when things are not clearly positive, but are somewhere in between, we can actually look through a molecular way and look for the ratio of the HER2 signal to the centromere sub-17. So when this ratio is elevated, like if the copy number is elevated, or if the ratio is more than 2, there are different criteria. So if the fish ratio is 2, or if the copy number is greater than 6, like it is in this figure, this would be an example of another type of HER2 positivity. So just know that from your pathology reports, if the HER2 is coming somewhere in the middle, there is another test that we do to be absolutely sure whether you're kind of falling into that HER2 clearly positive camp or you're more HER2 low. I know this can be all confusing, and I can tell you that even clinicians and researchers can get confused on this, but I thought it was still important to let you know about this additional test that we do. So before I talk about the therapeutics, I wanted to kind of take you to some takeaways in this chapter, which is that really HER2 positivity has come a long way, and it's really revolutionized how we think about different subtypes of breast cancer. And HER2 low is not classically thought of as a new subtype of breast cancer, but because of all the new therapies that I'm going to tell you about in the next few slides, it's really an important biomarker that has expanded the number of treatment options that we can give you. Right now, most of these studies are in the advanced metastatic cancer setting. However, there are ongoing studies also looking at kind of HER2 low status as well as HER2 positivity with these newer drugs in the more early stage setting. But typically the indications start in the more advanced setting, and then we move them forward to the early stage setting. So let's talk about those classically HER2 positive tumors, and then we'll move on to the HER2 low. So when that movie was made, what that movie covers with the discovery of Herceptin was 1998. And you can see just how many, so initially the indication for advanced breast cancer for Herceptin, then in 2005 to 2007, we got the Herceptin indication for early stage breast cancer, additional HER2 antibody, a monoclonal antibody known as Perjeta or pertuzumab was approved in combination with Herceptin in 2013. So lots of drugs, lots of amazing drugs. And then I'll spend a lot of time showing you data with this new HER2 antibody drug conjugate, which has an indication in breast cancer, but also in all solid tumors now that have HER2 positivity. So we've kind of gone to the more tumor agnostic indication, and I'll show you that. So truly, like, this has been a testimony to all the patients who participated in these clinical trials. I think it highlights human scientific innovation that in a span of this many years, we developed these very personalized therapies. Obviously, we still have a ways to go because success is defined as losing no patient to metastatic breast cancer or any other type of cancer. So I'm not saying we're done. I'm sorry, my dogs. But we truly have made tremendous discoveries in this area. And this antibody drug conjugate was approved as the first tumor agnostic HER2 directed therapy for tumors that are kind of identifying as clearly HER2 positive. We do not have an indication yet for all HER2 low metastatic solid tumors yet. The only indication we have is in HER2 low metastatic breast cancer. But I think this was really was quite an achievement because it didn't matter whether you had ovarian cancer, colon cancer, lung cancer, a sarcoma. Essentially, if your tumor biopsy showed clearly HER2 positive disease, we could use this new antibody drug conjugate. So what is it? What is this TDXD? Is like the medical term for it. The brand name for it is HER2. So I'll show you a schema here so you can kind of visually see what is happening and why that HER2 signal was so important here. So the left cloud, the gray cloud, imagine a HER2 positive cells, and then the yellow is the HER2 negative tumor cells. So this HER2 positive cell has places these HER2 protein cells, HER2 positive protein, and this drug comes in and essentially binds to this HER2 signal and gets inside the tumor cell. Many folks have described this as the Trojan horse model. It sneaks in and then releases its soldiers inside the tumor cell. So binds because we have that HER2 signal, gets inside the cell, and then only then does it the linker that's attaching the chemo portion to the antibody actually releases its chemo material so the tumor cell can die. So the drug is released. And then something interesting happens because even though even in a clearly HER2 positive cancer cell, not every tumor cell is going to have a HER2 signal. There's going to be a few tumor cells that do not. But what is the beauty of this elegant drug is that it has something called the bystander effect, meaning that the drug then also diffuses to other HER2 negative cells. And so not only kills HER2 positive cancer cells, but also HER2 negative cells. So this was a schema that was developed by my colleague, Pat Lorusso, who just completed her term as the AACR president. But I think it really, and this mechanism applies to other antibody drug conjugates, which is what this class of drug is. So we always have an antibody that attaches to a protein, the drug is released, and then some of the drug leaks out to other cells, amplifying the effect. And so data on this drug have been just all over the place. I don't want to emphasize too much the many clinical trials, but I do want to highlight when this trial, when Destiny Breast 03 was presented for the first time in one of our national oncology meetings, it was a standing ovation because for the first time, essentially, they took patients who had a progression after receiving Herceptin and chemo, and they were randomized to receive this newer drug versus this older drug. And again, you don't have to be a statistician to see that really we don't see curves like this often in oncology where there was this is the older therapy, this is the newer therapy. And so incredible improvement in outcomes in patients who had patients where chemotherapy and Herceptin had previously failed them. And so, and additionally, what was shown is that overall quality of life and all those things were able to be maintained, and even for many patients actually favored the new drug, because as we treated the cancer better, they had a better sense of well-being. Now, this is not to say that it does not have side effects and all those things, and that's one of my research areas. So in no way am I minimizing the toxicities of these therapies, but really I think do want to focus more this talk on just the remarkable discoveries that led to kind of these more HER2 personalized therapies. And it has absolutely changed my practice. I've had patients who are really struggling with symptom burden from their cancer not being under control, and I give this drug, and we're able to thankfully improve both their disease control as well as their well-being. And then what's happening is there's multiple other HER2 directed drugs. So we've really gone beyond the classic old Herceptin. It was foundational, but now we have multiple drugs, including kind of back to this HER2 protein being that growth antenna, and then kind of these small molecule inhibitors essentially go and attach, they penetrate, and they go and attach to these different kinase domains that are part of the HER2 protein, and then dampen the ability of the HER2 signal to kind of amplify. And because they're small, they're very good at penetrating that blood-brain barrier. So they've been quite effective for CNS, central nervous system metastases. And so this is just, it's not just about antibody drug conjugates, but lots of new drugs in this area. So we are really have made a lot of advances for HER2 positive metastatic breast cancer. These drugs are now being studied in the early stage, high-risk disease stage, patients who maybe did not achieve a complete pathologic response with traditional chemo and Herceptin. On trial, they were given antibody drug conjugates, and we're waiting for kind of results of those trials. And then really using these oral HER2 drugs to target kind of particularly brain metastasis. And what is extra exciting is that when I started out my career, I would tell my patients with metastatic breast cancer that unfortunately this is a treatable but not curable disease. And I think there is a lot of hope right now that HER2 positive metastatic breast cancer can actually be perhaps one of the subtypes of breast cancer that we may be able to in the near future be able to cure due to these advances in HER2 directed therapies. So moving on to HER2 low, which is the bulk of our cancers. So the study that led to the approval of the same drug that I showed you the pictures of with the cartoon and HER2 or TDXD was the Destiny Breast 04 trial. And these were patients who kind of had that little bit of HER2 signal, just like you picked out on those pictures that I showed you, playing pathologist. These were those tumors, and these were either hormone receptor positive or triple negative tumors that had that little bit of HER2 low signal, and they were randomized to get that new, smarter HER2 drug therapy versus some of our traditional 30-year-old chemotherapies. And what the results showed again was that the new therapy, when we smartly target that HER2 low signal, it leads to better outcomes. And this was shown in hormone receptor positive cancers, and it was also shown in all patients and also in a smaller subset of triple negative tumors. So it was the first proof of principle that, you know, we've been ignoring HER2 low. When I started my career, I would see these HER2 low tumors, I didn't have a drug for it. So it was, I didn't know what to do with that information. But now that we have a drug, we can actually act on it. So our progress notes in the electronic medical record have actually changed. Our pathology reports have changed. We are now calling out HER2 low status. And this is showing again that even in the hormone receptor negative tumors, these are triple negative tumors, which have very aggressive biology, having that HER2 signal leads to improvement of quite a significant amount when we use these HER2-directed therapy. And people like to joke, we are not the funniest bunch oncologists, but the joke here is how low can you go? And so, once we had the indication for the HER2 low tumors, the question was, well, what if it's really, really low? What if it's that faint staining that you were all squinting to see? And so this was the next study called Destiny 06 with the idea that things that I think we kind of convinced ourselves that HER2 low here was definitely deriving benefit. But what if it was just a tiny, tiny, faint signal? Kind of like I had you kind of squint extra hard to see. If we just had less than 10% of the tumors actually picking up a little bit of signal, what we used to call zero. Now, these are really zero or null, but if they just pick up just a little, this would be ultra low. And again, what we saw was that, the same drug can be so powerful that it just really needs that little bit of HER2 protein, and it's able to internalize in the cell. And the curves are not maybe as dramatic as when things were really, really positive, but still clinically meaningful and clinically significant, and that patients were able to derive benefit. And so now our pie graph is changing. So if you remember kind of some of the pie graphs I showed you initially, as we gathered additional clinical trials, before we used to just kind of think in a binary way of HER2 positive, HER2 negative. That's when I started my talk for you. Then we kind of moved on to HER2 positive, HER2 low, or HER2 zero. And then and then now we have this extra category of HER2 ultra low. And now people are even questioning whether HER2 zero even exists, because can you even go lower and lower and lower? And so this is the future, possibly, where we are actually in the process of generating data for even zeros, because even the zeros may have ultra, ultra low levels of HER2. And as our drugs continue to improve, as our quantification continues to improve, really what this pie graph may look like is that everybody can derive potentially benefit, kind of more of a continuous spectrum of expression. So I'm sure I've kind of given you a lot of information and your head may be spinning. And I'm sorry about that. I do want to make your head spin a little bit more before I go, which is that, we've talked a lot about HER2 in this talk, but it's even more complicated than that, meaning that there is actually a HER family of proteins, EGFR or HER1, we have HER2, we have HER3, and we have HER4. And each of these transmits signals in different ways. And each of these sort of couples and uncouples with each other. And this is like part of this intricate machinery of how these tumor cells can evade our therapies and kind of overcome our therapies. But we're smarter than them. So now there's actually drugs that are targeting this HER3 pathway. And so just wanted to quickly kind of mention the HER3 antibody drug conjugate, which kind of same idea. The antibody goes after HER3 and then releases the chemo. And it was shown to be in preliminary studies to be effective across multiple subtypes of breast cancer. And larger studies are now going on with this agent. So I wanted to at least introduce that thought and really kind of share with you that we are going to be experiencing a very rapid growth of multiple drugs in this space. I think both be it in early stage breast cancer as well as other cancer types, I think the indications for the use of HER2 directed therapy will continue to expand. What I didn't spend time talking about in this talk, but happy to in the future, is really the toxicity management and toxicity management with these drugs, because that's a whole other talk, but in no way am I discounting the importance of that, but just wanted to kind of focus more on the biomarker today. And I just want to make sure I've left some time for questions from you guys. So I'm gonna stop sharing and happy to take questions.
Can I ask a
Wow.
question?
That was so good. Thank you. Yeah, really good. And I followed everything so beautifully, which is thanks to you, because sometimes it's really hard to follow and really understand the future. So I feel like I'm just going to jump in because I have a question, and then we can take the audience as well. I have a couple questions I wrote down. But when you were talking about how it's very difficult to understand HER2 low, how low can you go? And it's always up to the researcher and the scientist.
Yes.
Do you think that that's going to be a place where AI is going to be able to complement and help researchers determine that so we can be definite?
Yes, lots of there was a study that read out in ASCO that showed exactly that definitely bringing in digital pathology, AI quantification is absolutely important. The other is changing how we quantify things. So David Rim, who would be an incredible speaker for your group, has given a lot of incredible work in this area, showing that kind of these antibody stains can be quite unreliable, and really that he has developed a very much a direct quantification of that HER2 signal. So that's actually being tested now in a national clinical trial called Quantify Her. Which is in multiple sites across the country. And the idea is, the hypothesis is that if we have a more reliable, sensitive way of measuring HER2, that we may be able to better predict who might benefit from these therapies, and also not exclude patients because of errors of the eye. So his data are quite compelling, exactly what you're saying.
Yeah. And then I'm seeing that last pie chart actually was allowing for everyone almost to benefit from it if they have an expression at all, correct?
Yeah.
Like pie chart is really, we know that it works for HER2 positive.
Yes.
Now it's all the negative.
Yes.
Yeah, we're like HER2 low, HER2 very low, very, very low, right?
Yes.
So really that pie chart is going to be full, where
Yes.
that could be a line of treatment. And
Yes.
would that be a first line of treatment, Dr. Lustberg?
So what I didn't show you guys is that just a few months ago in ASCO, we have now data that really HER2 should be considered as the first line therapy in HER2 positive metastatic breast cancer. And so, yes, it does keep shifting to kind of earlier lines.
Earlier. Okay.
And I do want to emphasize that the more positive, it's not that the HER2 signal doesn't matter. I think the more positive you are, the more likely you're to benefit. But I think because as these drugs continue to improve, and we even go beyond HER2, and there's lots of other HER2 antibody drug conjugates in development that I didn't talk about, it may be just not as important. And the lower you get, you can still kind of
You can have some kind of benefit. Great. Thank you. Okay, no more questions from me. Jackie, I see your hand is raised. You want to unmute yourself?
Hi, can you hear me?
Yes.
Great. I actually think my question might be at the very end, you talked about toxicity, and that could be a whole nother presentation. And if you ever did that, I would love to hear it. But I am on Herceptin. I have metastatic breast cancer, and it's working very well. My concern is what it does to my your normal cells. So I know my heart is monitored, but I understand normal cells have HER2 positive. And so what can be done to protect cells that you don't want harmed? And I guess if you can briefly talk about some of the toxicity that you see, and maybe even like the occurrence of that, and what the, I'm throwing a loaded question out there and I apologize, but what the risk benefit analysis is to long-term use of a drug like Herceptin.
Great question. Yes, so Herceptin, by the function of how Herceptin works compared to Enhertu, Herceptin, for it to really internalize and impact a normal cell, the effect is much less because it tends to kind of really gravitate toward those clearly HER2 positive cells, whereas our normal cells have very little amounts. But to your point, absolutely, the heart monitoring, subclinical cardiac function reduction is something that we see with Herceptin use. My patients report sometimes fatigue and kind of fogginess sometimes on Herceptin. It tends to be most pronounced when it's combined with chemotherapy, not by itself. I think the hardest part about Herceptin for some of my patients is the fact that they have to come every 3 weeks, and just that the burden of having to come more frequently. So several studies are looking at the question of how long do we need to continue Herceptin in the metastatic setting if a patient has done well for a long time. So there is a trial called Stop HER2 that is asking that question. And these are patients who maybe have been on Herceptin for years and years and years. And it's a very pragmatic study that's asking the question, do we continue Herceptin or do we stop it? And patients get to choose because patients can have very strong feelings about it. So we are kind of thinking about your very wonderful question of how long do we go with Herceptin, especially if there's been an exceptional response. I do want to say that apart from if your cardiac monitoring has been good and you're tolerating it relatively good, it's been around for several decades now, and we're not seeing increased signal of additional kind of sneaky toxicities coming in. So I guess what I'm trying to say is overall, I think it's one of our safer drugs if you're otherwise tolerating it from a cardiac standpoint and kind of the time burden of coming into infusion suite.
Thank you.
Amazing. Okay, so we're going to do a little bit of jumping between the chat and those that have hand raises, Dr. Lustberg. So to get to Laura's question in the chat, if you're on a treatment targeting PIK3 and you also have HER2 low, can Enhertu be added to the treatment regimen?
It can be added after the PIK3 therapy has stopped serving you for whatever reason, either due to tumor progression or you're not tolerating it. But the two together would be too toxic. So I would not recommend combining it. But if at any time in the future you would need it, you can rest assured that you have a wonderful next therapy ahead of you.
Amazing. Great. We can bounce over to Jennifer with your hand raised.
Yeah.
Great. Thank you so much. I'm curious about the medications that don't break the blood-brain barrier, right? So the normal treatment for HER2 is, the traditional chemo and Herceptin, but none of those break the blood-brain barrier. So in my circumstance, it went to my brain. And so what is the research now? And now I'm on Xeloda and tucatinib as well as Herceptin, but it's kind of past that point, right? So it already went to my brain. I've had CyberKnife and had great results, but it's still an issue. So where are we headed with perhaps putting HER2, because there's a higher incidence of metastasis to the brain, to put these folks on, like me, on medications that do break the blood-brain barrier beforehand rather than as a reaction, to be, proactive?
Yeah, wonderful question, and it really highlights the gaps. So there is progress happening, and I'm sorry that it didn't happen enough for in your particular case. So one is that tucatinib medication was actually studied in early stage high risk HER2 positive disease, where tucatinib and Kadcyla were used in combination. So the COMPASS residual disease study was a national study, which is doing exactly what you're proposing, where tucatinib was added as a preventative strategy. We don't know if it achieved it because the results have not matured enough, but the idea was take hundreds of patients in this national study, and the tucatinib was essentially given preventatively to see if we have better overall outcomes and also lower rates of CNS disease. So that's one. Two, Destiny-09, which was just read out, essentially we're moving HER2 trastuzumab deruxtecan to that first line setting in HER2 positive metastatic breast cancer. And what I didn't mention is that T-DXd also has very exquisite CNS activity. So in Destiny-11, which was presented in a European meeting, really what they saw is that even though it's an antibody and we think of antibodies as being bulky, for a number of reasons, and HER2 actually also has good CNS activity. So the hope is that by moving HER2 to that first line metastatic setting, we're also going to hopefully reduce CNS metastases. And then there's a number of other small molecule inhibitors that are in development that will also have greater CNS activity. So lots of unmet need that is being recognized in this area.
Do you have any idea when that will become customary? Like when will the study be completed and possibly having HER2 as a customary procedure?
So HER2 for the first line, HER2 positive breast cancer is expected to be to have potentially registration status by early January of 2026.
Okay, great. Thank you.
Great. Linda, I see you have a message in the chat, a question, but then you have your hand raised. So why don't you just, yeah, go on mute.
I'm unmuted now.
Unmute, yep.
Can you hear me?
Yes.
Yep.
Okay. I had excellent response with minimal side effects to HER2 for 3 years until this week. And I got major progression in my liver and some lymph nodes. What is the next step?
Yeah, so I'm sorry for your hard week. So I think depending on your prior therapies, and you're welcome to, you can say it here, or I'm going to put my email in the chat. You're welcome to email me. But depending on whether you have had tucatinib-based therapy before, typically if you have progressed on HER2, typically we tend to kind of toggle between tucatinib-based therapy versus HER2. There's also several new HER2-directed antibody drug conjugate trials, so exploring clinical trials in this space. And then there's also, you know, we kept saying Herceptin has improved. There's also a whole host of what we call Herceptin doublets, when we combine Herceptin with other traditional chemotherapy drugs, and those are also available as treatment options. So kind of not knowing all the details, but just sounds like you have lots of options, and I think happy to chat.
Thank you.
That's great. Linda, I would definitely grab her email if you
I will do that for
you have
sure.
it. Yeah, you have such a force here. Okay, Erin.
Yep. You want to pop into
okay.
Sarah? She's got a great question in the chat about time frame in terms of shrinking tumors with HER2 for those with stage 4. Is there a typical time frame that someone might see a change?
Within a month or less. It's very rapid.
That's amazing. Okay, great.
Yeah.
Yeah, we can pop over to Rita with her hand raised.
Yes, hi, thank you. Dr. Mariam, I wanted to ask you about +1 40%. What does it mean to have 40%? What are the implications? And if it's a personalized decision of the pathologist, about and the implications of the treatment after the 40%. If you could talk about it a little bit.
So the percentage refers to how, so typically if we take 100 cells, how many of those cells are picking up some type of a signal? So in this particular case, 40 out of 100 cells are picking up the signal, 60 out of 100 are not. And so there's like a specific scoring criteria, which depending on how strong the signal is, sometimes 40% would actually classify as a truly HER2 positive tumors and not HER2 low. But if it's really weak membrane staining is probably why you're being told it's HER2 low. I would have to see the report. But I think what it tells me is that HER2 in the advanced care set in the advanced cancer setting would be an option if your tumor is an advanced breast cancer. So I think it shows again that the signal is there. The signal is there.
Okay, excellent. I'll email you
Sure.
tomorrow the
Sure.
report and we can
Happy
maybe,
to
I'll
happy to look
appreciate
at it.
Thank you
Happy
so
to.
much. Thank you. Thank you.
Wonderful. Okay. And we have Melissa in the chat who is asking, she's strongly hormone positive stage 2B, but HER2 low. Would you favor a CDK4/6 inhibitor after finishing Herceptin Perjeta treatment, or Nerlynx, or both as an additional treatment on top of hormone therapy?
Yes, so you were HER2 low, but you were treated with HP in the early stage setting, because currently, I just wonder if you were truly HER2 low or truly HER2 positive, because in the early stage setting outside of a trial, we're not treating HER2 low tumors with HP. But if you were HER2 positive, I think with a stage 2B, if you're younger, I would consider Nerlynx. We have more data, particularly for these hormone receptor positive, HER2 positive tumors that are high risk. So I would favor Nerlynx in this setting for better CNS penetration if you were indeed HER2 positive. If you were more HER2 low, then the evidence would be stronger in terms of using a CDK4/6 inhibitor like abemaciclib or ribociclib. So happy to get an email with your actual pathology report just to see which one you were exactly.
Thank you so much. I can send that to you. I appreciate it.
Wonderful. All right, and we have Lakista. Do you want to unmute there?
Hello. Hey, how are you ladies doing this evening?
Good, thank you.
I have a quick question. I'm actually triple negative. And I was diagnosed upon first diagnosis in December with stage 4 with already having mixed to my liver, lymph nodes, and my bone. My question is, I started treatment at the beginning of January and was initially put on nib-paclitaxel. And then my PDL1 came back. It was high enough, so I was changed to Taxol and to Keytruda. My question is, I've had very positive results from the Taxol and the Keytruda. I've had 2 sets of scans, pertaining to my CAT scans and my MRIs, and my tumors are continuing to decrease in size, and I've been stable with my bone mets as well. My question is, in the event that my tumors did start to increase in size, would it make more sense for me to be tried on the Trodelvy? Because I heard that, they're making strides using Trodelvy versus, that or the Keytruda. But in the event I had to change, do you think it would make more sense to have my oncologist go to the Trodelvy or try the HER2?
Great question. And I can say that we actively debate this. So I imagine you're also HER2 low, which is why you're bringing up HER2. So the ASCENT study was the largest study with Trodelvy. And so they had hundreds of patients with triple negative breast cancer, whereas Destiny-04 with HER2 only had about 65 patients with triple negative breast cancer. So if we went by sheer amount of data, without knowing all the details of your case, I would say probably most of us would recommend Trodelvy or sacituzumab in your particular case because the data are a little bit stronger in triple negative breast cancer. And then in the future, if you needed something like HER2, it could still be tried after Trodelvy.
Okay, thank you. I appreciate that.
Sure.
Great. All right, I think we got them all, Erin. Dr. Lustberg, I can't thank you enough that you make yourself available to our community in such a personal way. It gets me choked up because I know how much information is so needed to have our patients understand their next steps and understanding what's new and up and coming. And we appreciate that you make yourself so available. So your expertise is so appreciated. Thank you.
Such amazing questions. And I'm in clinic tomorrow. So if I don't immediately respond to your email, I'll catch up over the weekend. I will not ignore emails. If I don't respond to you by the weekend, please send again or just kind of communicate with the moderators because sometimes emails get blocked. So happy to help.
Perfect. Yep, please do. You have Erin, everybody in the community, you know Erin's email, epellegrin@uniteforher.org, and then of course my own, sweldon@uniteforher.org. And then if you don't remember those names, info@uniteforher.org.
Or nutrition@uniteforher.org. You will find us one way or the other.
You will. All right. Well, Dr. Lustberg, you
Thank
have
you.
a wonderful evening. Thank you so much for being here. And we appreciate you. It was such an incredible presentation for all of us. And we're very excited about the future of,
Thank you.
yeah.
Thank you.
Hello.
Bye-bye.
Thank you.
Thank you.
Bye.
Amazing.
Yeah, it's good.
So good. So, and
I
thank you so
remember
much.
that day, Erin, just an FYI, in 2022, when there was a standing ovation for Destiny. And I remember that. Yeah, at ASCO in Chicago.
I remember you coming home and sharing with our staff how exciting and chilling it was to hear the news. So
See the progress. Yeah.
oh, it's wonderful. Wonderful.
Yeah.
So she shares a lot to give us a lot of hope and to give our community a lot of hope.
Agree.
So that is something to look forward to.
Agree. Yeah.
Amazing.
Well, thank you everybody for attending tonight. As always, we always want to thank our sponsors. We can't do what we do without them, right? They are extraordinary. And our Unite for Connect could not be possible without the support of our presenting sponsors, West, Merck, Lilly, Novartis, and Gilead Sciences, with additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo. And then we have supporting sponsors, AbbVie and TerraSera Therapeutics.
Absolutely. And don't forget to join us through the rest of August. So next Wednesday, August 13th, we will be having our virtual hangout. We'll be doing a little adult coloring together with our art therapist, Grace Childers, and our focus will be on scanxiety. So we know that that is a topic that comes up when it's time for scans, waiting for results. There's a lot of emotions that are provoked, and she will be teaching us how to use creative outlets like coloring to soothe that stress and anxiety. So that is August 13th, 5 p.m. Eastern time over Zoom. And then you will have our entire dietitian team on the 21st at 6 p.m. for our second speaker series of the month. And we will be highlighting that nutrition-focused treatment toolkit. So each one of us will be highlighting one of those treatment specifics. Immunotherapy, hormone therapy, chemotherapy, radiation, and talking a little bit how you can use nutrition to prepare yourself and help yourself through that regimen. So be sure to join us. You can register at uniteforher.org/UFHconnect. All of this will be promoted on our social media, so be sure to follow us. And all of this will be recorded and available for viewing. So if you can't make any of our events, tap into our UFH Connect and watch at a later date, or share with someone that you know would love to hear this information.
Yeah. And if for chance we didn't get to any of your or all of your questions tonight, please email us. You see Erin's email right there. We will directly connect with Dr. Lustberg and get those answers to your questions. And then sometimes they are blocked. So just remember that emails are blocked in the hospital systems. So if for chance you're not getting through, again, email us and we will get to
Yep.
Dr. Lustberg. Yeah.
Perfect.
She is one of our advisors, Erin. I don't know if our community realizes that. And we are so grateful that we brought her on as one of our medical advisors. So it just keeps us very informed. We know how much integrative care helps with these types of side effects and symptoms. So when people talk about the fatigue being real, this is where we come in and we can help our community stay on treatment when they're getting such positive results, where otherwise it would be really hard and they have to abandon treatment. So that whole comprehensive approach just is so valuable, and we love working with our medical community in such tight association with all these new therapies.
Yeah.
All right,
Wonderful.
Erin. Well, that's a wrap. Yeah.
That's a wrap. Yep. Thank you so much for joining all of us tonight. Sue, thanks for spending our time together this evening.
Yeah.
And
always enjoy it.
hopefully we will see all of you next week.
Yep. Sounds good. All right. Good night, everybody. Thank
Good
you.
night.